All right. So hello, everyone. My name is Renice Owens, and we are so pleased that you all could join us for this week's lecture in Volume 7 of our No Neuropsychology Didactic Series that brings you lectures from experts in the field covering different topics each week. And this series was created by trainees and early career neuropsychologists, including standing members of No Neuropsychology Board, as well as members of our rotating committee. We would like to thank our 2023 sponsors for their generous financial support of the series. And before we start, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. So be sure to check it out, subscribe, and like our lectures to get first access to new content. And new to No Neuropsychology is our collaboration with APSN to bring you learning and discussion questions that are provided with specific lectures content. And you can access these on our website and through APSN. No Neuropsychology is also excited to announce that transcripts are now available for all lectures in volumes 1 and 2, and additional transcripts will be added over time. So here are the disclaimers for the series. And this training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Maggie Lanka for today's lecture titled Primary Care as a Front Door for Neuropsychology. And so Dr. Maggie Lanka is the Director of Neuropsychology and Cognitive Wellness and the Director of Population Behavioral Health at Cambridge Health Alliance. She is also the Assistant Professor of Psychology and Psychiatry at Harvard Medical School in the Division of Population Behavioral Health and Psychiatry. She oversees the implementation of measurement-based care in psychiatry and develops new programs geared towards precision medicine and improvement of patient-centered care through early identification and intervention of emergent behavioral health conditions. In neuropsychology, Dr. Lanka directs the neuropsychology service and oversees training of the neuropsychology postdoctoral fellows. In her clinical work, has been to specialize in the provision of multicultural neuropsychological assessments and understanding the factors influencing the assessment of patients, diverse backgrounds, and with psychotic illness. Her research has focused on improving neuropsychology assessments through investigation of clinical outcomes and stakeholder views of neuropsychological report writing and neurocognition of schizophrenia. She has innovated neuropsychological screenings in primary care, cognitive stabilization intervention during COVID-19, and guidelines for the provision of teleneuropsychology during COVID-19. She earned her PhD in cognitive psychology at Northeastern University and respecialized in clinical psychology as a postdoctoral fellow at the University of Massachusetts Amherst. And she completed her neuropsychology residency at Harvard Medical School. She is currently the president of the Society of Clinical Neuropsychology, Division 40 of the American Psychological Association, and the past president of the Massachusetts Psychological Association and the Massachusetts Neuropsychological Society. We are so excited to have you with us today, Dr. Lanka, and you can begin your lecture. Thank you.
Thank you so much, Renice, for that warm welcome. I'm going to jump right in by first sharing my screen. All right, is that working?
Looks great.
Wonderful. All right, welcome everyone. I am so enthusiastic about being here today. neuropsychology has just gained so much popularity, and it's such an important endeavor. I want to begin by thanking all of those who put this together and who are working so hard to really proliferate the field of neuropsychology, not only for trainees, but for neuropsychologists and those beyond our profession. Such an incredible endeavor. So thank you to all of those involved. All right, I am very excited to talk to you today about the work that I've been doing in primary care and actually merging the work of several facets of my work, both in population health and in neuropsychology. So I want to begin by talking about neuropsychology within a population health framework. What I'm going to do is I'm going to start with a 10,000 mile high view of what's going on in primary care and really the radical transformation that has been happening in primary care. I have been witness to this as I've been working in primary care for the last 10 years doing neuropsychology screens. And so this movement within primary care to really acknowledge, embrace, and reframe primary care work within a population health management framework is really an important piece to understand before we move into how neuropsychology works within primary care. I'm going to talk a little bit about really the importance and elevation and recognition of cognitive health across all medical illnesses, not just the neurological and psychiatric ones, which many of us were taught to really just solely recognize. Then I'll elaborate a little bit more about the role of neuropsychology in primary care and what some of the endeavors are within the work embedded in primary care, and discuss a little bit about neuropsychological stepped model of care. And then also look a little bit towards the future, and maybe not so distant future, but really what's happening now in terms of evolution and trends in neuropsychology, particularly within primary care, but honestly looking downstream into specialty care as well, which affects all of us, regardless of what area of neuropsychology we specialize in. All right, so I want to begin by really talking about how there's a real growing recognition about how cognitive health is important to overall health. It's affected by numerous diseases, and this will play a large role in how we understand population health. Before I do that, though, I want to begin at the beginning, which is how do you define population health? There's no one singular accepted definition of population health, which is part of the challenge in working in this field, but also a sort of a normal outgrowth of the fact that population health has come from different perspectives, and so as it is in blossoming and enlarging, we get to understand it in different ways. So it's an evolving field, and the understanding of what is population health is also evolving. But to sort of go to the sort of the basic core in terms of one of the basic definitions of population health. Population health really refers to the health status and health outcomes of a group of people, rather than considering just the health of one person at a time. And so for public health practitioners, it really means improving population understanding and optimizing the health of a population broadly defined by geography, not just what happens at the front door of a hospital, but really within the geographic area that a healthcare organization serves. And so for healthcare practitioners, improvements in healthcare really occur through policy and public health initiatives, which is very important because it affects overall health of the patients that eventually we will see. Unfortunately, there has been somewhat of a chasm between public health policy and healthcare. And with the growth of population health, the overall goal is really the merging and intersection and seamless flow from public health policy to healthcare. Healthcare providers may refer to a population as their patient panel or their team or their organization members. But what population health really wants to do is to have clinicians think of their panel as beyond the walls of the organization or the clinic, and really think about the health within the community. And why is that important? Well, we know from population health research that that there are many factors that determine actual health of persons in a geographic area. And only 10% of that is determined by the actual health care we receive. The United States spends over 2.7 trillion, probably more now since the statistic came out, on healthcare, which accounts for approximately 18% of our gross domestic product. However, only 10% is determined by the healthcare that we receive. And so 40 to 60% of the health of the population is actually determined by social determinants of health, like poverty, housing, nutrition, education, and the environment, like access to clean air, sidewalks, bike trails, etc. This is a staggering statistic, and it really should be humbling to all of us that what we are doing is really just focusing a lot of our work as healthcare providers on really barely the tip of the iceberg of what is actually happening in healthcare and in the health of our fellow Americans. These are all the conditions that really have been a consequence of us only focusing on the tip of the iceberg. What we know is that we have massive health disparities. We are very slow to detect early stage medical problems and relate to intervene. Very few receive minimally acceptable care. There's a high burden of disability across health disorders. We have a very high rate of mortality in proportion to our GDP. And we're not doing very well. So we really need to change the focus of what we do. Much of the current state of our healthcare is very disease-oriented. That tip of the iceberg that we take care of really happens when people become symptomatic and really progressed in their symptom stage as well. So we really need to push our healthcare reform to look at three main goals of health in order to improve the health of our population. We have to move from the individual patient to looking at how to take care of the population. So we go from individual to clinic to the actual health of the population. And how do we do this? We do this by three main goals: prevention, early detection, and intervention. Of course, this requires public policy, and it's going outside of healthcare per se, but we need to partner with the community for health initiatives in order to have improved health for everyone involved. Prevention, for example, happens to a large degree outside of healthcare, and it's guided by the public health policy. So as healthcare providers, we can also think of prevention and early detection and intervention at the first point of contact, be it primary care, be it in schools, be it in the legal system, be it in communities like elder community centers, we have to start partnering with our community centers in order to have a much more robust and comprehensive understanding of how to take care of the population at large. In neuropsychology, we also need to do this. This is not just a general healthcare problem. In neuropsychology, we should be challenged to look around and see how we could mitigate and change our field to really expand beyond disease identification at the later stages and understanding patients' cognition once they've been diagnosed with a disease. Now, we do this to a certain extent with mild cognitive impairment. All of the research in MCI has really helped us to detect and test for mild neurocognitive impairments and disorders at an earlier stage. But often we see these patients for MCI workups in tertiary care, where there already has been some workup of patients and possibly already the diagnosis of MCI. MCI, if we wanted to truly be helpful in healthcare, picking out and detecting, really should be happening at a larger level in the primary care centers. And so the conversation and emphasis moving from disease management to health management should also be happening and should primarily be happening in primary care as really a front door for neuropsychology. What better setting really to intervene and to do early detection than actual primary care? I'm not going to spend too long on this slide, but I want to be able to emphasize how primary care is really organizing within, or reorganizing, I should say, within a population framework that is really including and starting to embed a lot of public health practice into its framework. So that whereas public health practice has often, even as a field, focused on risk behaviors, disease and injury, mortality rates, even within public health practice, there has been an increased emphasis on looking upstream to those factors that really affect risk and disease and mortality, such as social inequities, such as institutional inequities, such as living conditions. And this is something that in neuropsychology, there has been a growing voice to look at social inequities and social determinants of health that can be contributing to cognitive health. More really needs to be done. Certainly, we know that social determinants of health are huge social and environmental factors that can have a significant impact on mental, physical, and cognitive health. But it's still really in its beginnings in terms of understanding. There are also multiple social determinants of health, such as the ones I just mentioned, and we still don't know enough in order to know how it impacts, which ones drive healthcare and impact healthcare the most, under what settings, and for what kinds of health conditions. We do know that the top 3 social determinants of health that really do impact at the level of once you reach to the front door of a health system is unemployment, housing, and obtaining food. And that really needs to be captured in every medical healthcare system at its point of entry. And I know in our institution and many other institutions, when patients come in and show up at the front door of the healthcare, we now have SDOH screeners that really do capture these 3 primary drivers, and patients are referred accordingly to get some social work assistance and social assistance, as well as their health care. But we need to understand more, especially as neuropsychologists, on how each of these factors, not only these top 3, but other social determinants of health can impact cognitive health. For example, we're learning that social isolation, for example, is one of the biggest drivers for early mortality. And so it could also be very strongly related in terms of dementia and other medical illnesses. More research is needed to understand this. All right, so I've talked about some of the drivers of that are affecting an organization and healthcare, and how population health is really important to consider. I want to also mention a couple of other really important and relevant factors about how primary care medicine is changing. What we also know about primary care and healthcare in general is that the range of illnesses and conditions that are treated in primary care is growing. Patients are actually living longer and healthier lives, but they're living decades longer with chronic diseases. This imposes a higher burden on primary care providers to continually monitor, assess, and treat conditions. And it increases patient burden of living with their conditions, many of which take a cognitive and emotional toll. So this raises the premium to understand the cognitive impact of certain diseases and how to best manage it. So what does cause cognitive problems? Well, many of us were taught that, of course, any brain disorder that affects the central nervous system will affect cognition. And so for a great many of us, we're very familiar with the fact that dementia, stroke, epilepsy, many neurological diseases, Parkinson's disease, multiple sclerosis, brain tumors, hydrocephalus, they're just some of the central nervous diseases that can impair cognition. We also are very familiar with the fact that neurodevelopmental conditions are known to affect cerebral morphology, such as spina bifida and other milder neurodevelopmental conditions as well, that can have cognitive impact, ADHD being one of them. Psychiatric illnesses are very well known to impair and or disrupt cognition, from mild psychiatric illnesses like a mild major depression to more severe, serious mental illnesses like a primary psychotic disorder like schizophrenia. All of these are very well known to affect cognition, and that historically is why neuropsychologists are typically embedded in neurology, neurosurgery, and psychiatry. What gets less of attention and understanding, though it has been around for a long time, and I put the front cover of a book that was part of my training years ago, and so it was a long time ago, on medical neuropsychology by Tarter and his colleagues, to really look at the impact of medical conditions on neuropsychology, on actual cognition. Even though medical conditions may not necessarily be direct impact drivers of central nervous system, they do and can affect cognition secondarily. We know that the brain is totally dependent on other organs and systems for maintaining its functional integrity, and it's susceptible to dysregulation. Brain metabolism depends on the vascular system to transport oxygen, glucose, and other nutrients. When an organ system is inefficient or unable to provide the brain with sufficient quantities of substances that are necessary for normal functioning, it can alter brain functioning. And so medical conditions, a vast array of them, can secondarily affect cognition and do affect cognition, which is really important for us to be able to tag, to detect, and to intervene early on. And this is part of the work of neuropsychologists who work in primary care. So just as an example, asthma can reduce oxygen levels to the brain, sleep apnea can reduce oxygen levels to the brain. All of these can have serious impact on cognition. Overly active organ systems can also disrupt cerebral functioning, like overactive thyroid, pituitary, adrenal glands, conditions that affect cognition most clearly, and there's been widespread documentation and research about that. Acute chronic liver diseases, for example, can also induce encephalopathies, which in turn have very direct cognitive disruptions. Also, really important to neuropsychologists, and particularly those that work in primary care, polypharmacy, we know, can very much disrupt cognition to the point of altering people's everyday functioning and lowering their everyday functioning. So understanding what medications affect cognition, and really the interplay of multiple medications, which, as I said before, as people are living longer, they have more conditions, and people have more medications on their treatment list. And so polypharmacy is really not the exception anymore. It's almost the rule. Likewise, long-term substance use can impair cognition as well. All of these conditions really do surface in primary care because people come to their primary care providers first. And so having a cognitive specialist in the primary care realm can really help with that early detection and early intervention. So what's the value of neuropsychology in primary care? Well, it's really assessing cognitive dysfunction in patients with medical, but I'd also say medical, neurological, and psychiatric problems, and at its first stage. And so we know that these conditions can lower cognitive impairment, but what I haven't mentioned yet is that they actually lower instrumental activities of daily living, and or in more extreme cases, actual activities of daily living. ADLs and IADLs can be pretty substantially affected by many of these conditions, and you see them in primary care. Not only that, patients with cognitive problems are known to have poor medical outcomes. And so that early intervention, that people have appropriate cognitive training, cognitive remediation, cognitive supports is really important to keep patients functioning as well as possible with their medical conditions. So therefore, cognition should really be considered. I know I'm speaking to the converted here, but it really should be considered an important element of population health models. For those of us in primary care, these considerations of the importance of cognition for all individuals across the lifespan is a normal occurrence. And we think of population cognitive health is but a natural extension, really ensuring holistic approach to healthcare. All right. So how do we actually do our work in neuropsychology in primary care? It's slightly different. I also work in psychiatry, and it is different in terms of how we approach and what kinds of evaluations we do in primary care. Primary care is similar to primary care models. Neuropsychology has also been adapting a stepped care approach. I think long past are the days that every single person for every single condition, whether they're seen in primary care, neurology, or any other service where neuropsychologists are embedded, like oncology, for example, get exactly the same protocol, get exactly the same length of comprehensive treatment. We now are really revising our field to towards a stepped approach care. And what do I mean by stepped approach care? It's really the idea or the perspective that neuropsychological assessments conform to what is required or what the referral question is, such that if a patient comes in with a milder condition or responds to a least invasive treatment, then treatment is maintained. But if the patient's status remains the same or declines, gets worse, then the more intensive level of treatment is implemented. So for example, a patient shows up at his or her primary care provider's office complaining of headaches and symptoms. Not every patient will get an MRI as a first step to evaluating that headache. Primary care providers will do a clinical evaluation, potentially prescribe a medication. If it is clear that the patient has migraines, will be prescribed migraine medication. If the patient is not relieved by that, then they might either change medication to another kind of medication or refer to a neurologist. A neurologist may then treat in a more specialized way in terms of understanding the panoply of headaches and understanding their cluster headaches and migraines and other kinds of headaches and change medications. And then if it doesn't work, then the neurologist may go on to get an MRI, order an MRI for the patient. So there's a progression from a least invasive to a more invasive level or more comprehensive level of treatment. And so the same neuropsychological stepped model of care is also proliferating, not only I would say in primary care, but also in other specialties, where the lowest level or the least invasive or perhaps the initial assessment may be some consultations or cognitive screens, which is different than a brief neuropsychological assessment. There's been wonderful papers by Teresa Roebuck Spencer and Katie Block on cognitive screens and differentiating cognitive screens from neuropsychological assessments. So I refer you to those. In primary care, we've done brief neuropsychological assessments, and I've written about that. And then neuropsychological assessments that are much more comprehensive, usually 2-3 hours, happen only after step 0 and step 1 are proceeded, unless there is a compelling reason to go straight to a more comprehensive level of care. And then certainly neuropsychological assessments with intervention would be at the highest level. So let's look at the brief neuropsychological assessments. These are different than cognitive screens. Cognitive screens can happen within 5 minutes, can be done by a paraprofessional, doesn't need to be done by a neuropsychologist. Typically will be something like the mini-cog or the MOCA. In a brief neuropsychological assessment that we generally do in primary care, now we're looking at a little bit more comprehensive, 60 to 90 minutes, takes into account a clinical interview. Because we're neuropsychologists, we do more than just screen in or out possible cognitive problems, but we're qualified to diagnose. So that may involve a diagnosis. And we use select and very brief tests, or we may not use tests, but we use a comprehensive clinical diagnostic interview for which we use our cognitive expertise, like doing ADHD evaluations in primary care, which primary care providers, by the way, absolutely are very thankful for, because it is a growing referral within primary care. So this is like a step up from the cognitive screens. And just to give you an idea of the real, of one type of BNA that we've been doing in primary care is one for dementia. We also have separate ones for ADHD, and there can be many others. I know my colleagues who work in primary care have looked at other kinds of brief neuropsychological assessments as well. But if we just focus on assessment, I want to be able to convince to you today that in fact there is a lot of economic as well as health gains that can be gained from having these brief neuropsychological assessments in primary care. We know that dementia is a growing chronic disease with complications that are typically managed in primary care. And though I also do dementia evaluations in psychiatry, really primary care providers are the front door for these kinds of symptoms. And so patients do seek their primary care providers first, often because of comorbid illness, safety concerns, or changes in their behavioral or functioning status. Dementia diagnoses often happen in primary care, but they can go unrecognized. And so having specific cognitive screening is really important at a primary care level. And as if, again, I'm preaching to the converted, but for those of us who work in primary care, we understand that this is also an economic, there's huge economic impact of dementia. And so catching it early can save really a tremendous amount for our economy that can be flowed back into more useful ways into healthcare. And I just put on here the expenditures and the total economic impact for poor cognitive health is really quite staggering. And not to mention, this is all growing. As we know, we have a growing aging population. And so for dementia, even though cognitive declines serve as an early marker for the disease, systematic widespread cognitive screening is still lacking, and it's very costly. We really need to have improvement towards earlier detection and intervention at the milder stages of cognitive impairment. What do we get out of that? We'll have greater, better diagnosis with greater sensitivity to diagnosis than cognitive screens. Remember, the cognitive screens are not diagnostic. They only serve to rule in or out a cognitive problem. So having something a little bit more comprehensive, like a BNA, can really help with the actual diagnosis. It can help with treatments, more precise treatment recommendations. It can help with efficiency, eliminate the need for longer neuropsychological assessments. And it also, by the way, it can really make more efficient the triage system downstream into specialty care. Being both in psychiatry and primary care, I have noticed that we get better referrals in psychiatry when we have an efficient cognitive screening process and brief neuropsychological assessments in primary care. Because now we don't get the undifferentiated cognitive folks with cognitive problems. We get folks that have been not only screened in primary care, but have done dementia DNAs and now go on to a higher level in the specialty clinics. All right, I'm going to skip that because we're running out of time, but you'll see it in your slides. And I just want to emphasize that in primary care, what we get out of doing both enhanced cognitive screening and brief neuropsychological assessments is that we're getting we're getting early detection. And what we now also need to focus on, remember those three pillars of population health: early detection, prevention, and intervention. We need to think about these in primary care. So with the cognitive screening and the brief neuropsychological assessments, we're working towards early detection. We also have to be mindful of how do we improve prevention. And this comes with putting together wellness programs, which also have been proliferating across the country in different healthcare organizations. The MindWell programs are a good example of that have been focused mainly on mood disorder prevention, but can very easily expand to consider cognitive health and wellness programs, cognitive programs. Wellness programs have also been sprouting in communities. So this is another way in which primary care can work in tandem and lockstep with communities to really help each other with putting together and knowing their patients across different wellness programs. There are plenty of neuropsychologists as well that have spoken at our national conferences who've talked about their private practice wellness programs in conjunction with their neuropsychological evaluation. What a wonderful way to really start augmenting and using neuropsychological expertise in putting together cognitive wellness programs. And some of these wellness programs not only include cognitive wellness, but include exercise and nutrition, as well as cognitive training. This is wonderful, not only preventive work, but also intervention as well. And so I mentioned a couple of other intervention programs that are happening across the country. The HABIT program, well known in the Mayo Clinic, and then multiple other cognitive training programs that are happening throughout different programs, not only in primary care, but in specialty programs. For example, cognitive enhancement training for psychosis are evidence-based programs that have been emerging and been occurring in psychiatry departments. There have been memory programs in neurology departments. So this is another area in which neuropsychologists could really play a large role in the intervention piece as well. All right, so how do we sort of look into the future of primary care and neuropsychology and putting this within a perspective of population health? Well, this may seem, all of the work in terms of understanding how do you take care of a population when in reality we can almost barely take care of the patients that come through our door. Well, part of this is sort of looking at the different levels of cognitive screening that need to happen early on, not only at the front door of the healthcare institution, but also in the community. But also, and more importantly, is leveraging technology and the emergence of different cognitive monitoring and digital tools to help us with tracking and early detecting of cognitive issues. So, for example, there have been, and I'm sure you're all aware of, the growing cognitive digital tools that seem to be sprouting literally one a month that still need quite a bit of work in terms of validation and understanding how it relates to different conditions. But that work is happening, and I'm optimistic it'll continue to proliferate in a way that will help neuropsychologists, so that if we can have cognitive tools that where patients, for example, can on their cell phones monitor their own cognition on a periodic level. Some of that data can flow into their healthcare records, or the healthcare primary care can send out a digital cognitive tool for which patients can do at-home cognitive screening. Again, to screen in, screen out, we can start really expanding the tentacles of cognitive screening out into the community, so that when patients arrive for their annual checkup or arrive at the primary care center, there could be theoretically already data in the medical record as to whether or not these patients or some of these patients have cognitive symptoms that need to be looked at more carefully. Healthcare organizations have also been incorporating measurement-based care, and I know that the American Psychological Association is working hard with advisory committee on measurement-based care and looking how to assess people's mood symptoms at a constant, systematic, and periodic level in primary care, and also in psychiatry and in psychological practices, as a way for there to be not only monitoring of symptoms, but detection of early mood symptoms. Well, we need to have the same thing happen for cognitive health. We need cognitive health monitoring as well. And I do believe it's coming. It just hasn't really quite been instituted yet. But certainly measurement-based care for mood symptoms are happening, and it is growing and growing more widely. Using digital knowledge to help leverage not only early detection, but using artificial intelligence to understand who may be at higher risk for developing dementia, for example, can all be done through artificial intelligence analyses. This is a way for us to really leverage technology to help with healthcare. I want to leave plenty of time for questions, so I'll begin to wrap it up and emphasize the main points that I talked about today. Primarily how neuropsychology in primary care can serve as the front door for cognitive health. I hope I've made that argument strongly enough. Also, that neuropsychology practice should really be re-envisioned within population health. We certainly are at an inflection point in our profession. We know that neuropsychologists are really overwhelmed with so many referrals. Waiting lists just keep getting longer and longer. If we start re-envisioning our work within this population health framework that spans not only different types of evaluations or levels of evaluation, but also the different pillars of population health and expanding cognitive detection in primary care and in the communities, I think we can work more efficiently downstream into specialty care as well. And really, there has been increasing recognition of the importance of cognitive health. I think that is going to continue to happen. There has been increased depth level of care to help screen, identify, and diagnose and treat cognitive symptoms, improve medical treatment and patient overall functioning. That in primary care, we have regular monitoring of cognition and cognitive vital signs that can lead to more efficient and cost-effective treatment. And future trends will include more widespread and frequent screening of cognitive health to improve these pillars as well. And so what's our neuropsychology call to action here? There's a lot that we could do, and there's a lot that is being done. And I think we can really divvy this up in terms of professional level call to action, practice level, community leadership level, and education level. At the neuropsychologist level, we really need to have greater understanding of the role of public health and how it impacts cognition and how it impacts patients and the community that we serve. And we need to demonstrate awareness of the integration efforts between primary care and public health, as well as specialty care as well. At the practice level, redefining population health based on a public health definition as geographic, as opposed to just someone's practice panel, is going to be really important in understanding understanding the cognitive health of our population in general. We need to identify critical social factors that impact our cognitive health, particularly with increased work on how social determinants of health really impact cognitive health as well. And there needs to be greater continuous collaboration and communication with public health infrastructure to operate as a continuous unit with a common goal. At the community level, we should facilitate greater collaboration with community centers, with different community agencies, in order to have greater cooperation and greater understanding of the impact of cognition on healthcare. And at the educational level, we need to really drive change by teaching our graduate students, our trainees, on how to ensure about neuropsychology within a population health framework, about how to increase our work in primary care to really ensure that neuropsychologists of tomorrow are prepared for a much more integrated health system that includes not only healthcare, but the health of a population. So thank you. I'm going to leave it at that. And I think we have quite a few minutes for questions. So I'm happy to engage.
Well, thank you so much, Dr. Lenka, for that wonderful lecture. I was learning a lot about how to really integrate neuropsychology into primary care. I am very excited about the way the field is moving. And there's a lot of people that have questions too about kind of just how do we do this? How do we kind of make those connections with primary care providers and their openness and willingness to have neuropsychology come in? So can you speak a little bit about how to really build that collaboration?
Yes, those are great questions. And I want to be mindful too, because I think sometimes when, I know I'll speak for myself when I give this talk, but I think when other colleagues give this talk, we often are sort of coming from the framework of neuropsychologists working already in healthcare institutions and not necessarily account for really, probably the majority of neuropsychologists, but if not, a sizable number of neuropsychologists who work in private practice. So in some ways, they are already out in the community, embedded in the community. So they too, I mean, they're doing the good work of being embedded in the community. I would say there's multiple ways to sort of tackle your question, depending on where you work, whether you're in the community in private practice or whether you're in healthcare, and also what area or what specialty. I would say in order for population cognitive health to be more successful, we need to have a larger presence in primary care. And that means really whether, again, when you're working in private practice or in specialty care, if you're working in specialty care, there needs to be sort of more drive towards getting the referrals that you get from our specialists to really flow back to primary care providers. Oftentimes, I think specialty cares work in their own little bubble. I think our EMRs do a good job of making sure that everybody at least has access to the same information by virtue of a person's electronic record. But making a point to include primary care providers in any kind of tertiary care is absolutely essential to try to keep everybody in the same loop. For neuropsychologists who are already in contact with primary care, having a greater presence in really helping to educate primary care providers on the importance of and the relevance of screening for cognitive symptoms is absolutely crucial. Unfortunately, the statistics on the annual wellness checkup that really is CMS mandated for every person over the age of 65 in primary care, those numbers are staggeringly low. Really less than 20% of folks get their annual wellness checkup in primary care. And I don't want to put blame on primary care providers. They are so overwhelmed these days. And there are a good portion of folks who over 65 who don't have cognitive problems. So it might not be foremost on their mind. But again, if we were to really work in tandem here, an annual cognitive screening, whether you are symptomatic or not, will really help track where your cognition is. And wouldn't it be wonderful for those in neurology or in tertiary care to be able to have, let's say, 3 annual MOCAs or 3 annual mini COGs in the EMR, for 5 years before it actually got to the neuropsychologist working in neurology for a dementia question. That would be wonderful, or any other condition for that matter. We would have so much pre-morbid data that would really improve our work. For those in private practice, having more connections to other agencies that healthcare organizations don't necessarily have strong connections, like elder care services, senior centers, those kinds of centers is a way for private practice clinicians to assist with cognitive screenings for those patients, so that this work can be done really in multiple directions by neuropsychologists in many different domains. So I can't hear you, Renice. Is that just me?
I was muted. The things about Zoom, huh? But thank you so much for that insight. That was very helpful. There's another question too. You mentioned the social determinants of health when you're thinking about population health. And so I'm wondering, from a neuropsychologist lens, when you're doing these screeners and when you're doing different assessments in primary care, how do you then incorporate the social determinants of health when you're considering the patient that you're working with?
Oh, what is such a great question. And I tell you, this has been an ongoing conversation in our clinic with our fellows in studying this. Certainly what we understand, what we know about social determinants of health and how it affects a person's overall health is emerging. It's growing. We know that it's happening. How it actually affects cognitive health and in what ways, there's still so much to be done. I mean, to our credit, in neuropsychology, we have long since spent a lot of time with our norms, considering race, education level, gender, but these are woefully outdated. There has to be a new conceptualization of how we take into account these SDOH variables in a comprehensive way. And there has to be more specific research to understand how it impacts cognitive health and in what way to what kind of different conditions as well. This is really the call to the future for a lot of us. I think at a very individual level, certainly in our neuropsychological interviews, we always look at, and I think most neuropsychologists, if not all, are trained to do so, consider education, consider unemployment, housing, consider access, consider what neighborhoods, considering SES. I mean, we really do consider this at an individual level. We just need to know what the impacts of this is at a more at a higher level and at a more group level, so that we can know how it impacts disease and our findings more systematically.
Yeah, that's really interesting. A lot more to come from clinical work as well as science. Have you noticed any thing more for the future in regards to kind of just research out there in regards to neuropsych and primary care and social determinants of health?
I don't know if I would necessarily say that I'm familiar with neuropsych and primary care in terms of social determinants of health vis-a-vis actual research that's being done. It might be, I'm just not familiar with that. But certainly, as I had mentioned to you earlier, we in our institution, and I know in many institutions, social determinants of health screeners are now part of a regular process of screening. Every new patient, every single year, once a year, gets a social determinant of health screener. And so in primary care, when I open up somebody's EMR, I immediately can see, has there been unemployment? Has there been nutritional distress in terms of inefficient nutrition? Has there been other kinds of SCS that is factoring in housing in particular? So it's in the front of the mind. It is part of the consideration of the picture, and it's in every EMR patient that I see in primary care. So it's starting to fold in a very clinical way, and I hope that that continues to expand.
Yeah, that's really great for the future of neuropsychology. Well, thank you so much, Dr. Lenka, for this wonderful information that you provided today, this wonderful lecture. I learned a lot, and I know we all learned a lot from you. So thank you for really teaching us and letting us know how the field is moving forward.
You're welcome, Denise, and thank you to everyone. Thank you for having me. It was a real pleasure.
Yes, thank you.